Hi, good evening, everyone. We'd like to welcome Ms. Wong, who has actually given us a talk, a webinar on stomach care and was really well accepted. She's extremely good teacher and very passionate about her work, very detailed, and I really like her presentation. I would like, without further ado, to invite her to give a talk this time on wound management. So, Ms. Wong?
Okay, thank you, Dr. Betty. I share screen first, yeah? Okay. Okay, a very good evening to Dr. Betty and all of you. I'm actually very honored to have the opportunity to share with you something on wound management this evening. Without further ado, I will go to the topics, yeah?
Yeah.
Okay, this evening I will be actually will be sharing about the different types of wounds, wound assessment, followed by the management briefly. Okay, the first slide you can see actually there are types of wound. I think most of you nurses here, you may have managed wound before. And the wound is actually can be divided into two broad categories, like the acute wounds and also the chronic wounds. So for acute wound, if you can see from here, it is actually the okay, I can show you here the incisional wound, burn wound. Of course, some of the wounds like abrasion, even laceration, all these are acute wounds. Then the chronic wounds are like diabetic wound, pressure injury, you have venous ulcer, arterial ulcer, fungating wound, including the dehiscent wound also. And also fistula. Fistula, at first I thought I want to put in some slide, but I think it's too much. So I actually removed the slide on fungating wound. Okay, we start off with acute wound. Acute wound is actually basically the wound that is healed by primary intention, meaning that the wound can actually heal without intervention of a surgery intervention to close it, yeah. And also it is actually with minimal tissue loss. The edges of the wound is in closed position, so you can actually go back to the near normal position, yeah. And also besides that, it is also the acute wound also has predicted time of healing. Normally, we say if it's wounds like incisional wound is about 10 to 14 days, yeah, and it has got minimal scarring. Although it has got predictable time of healing, but at times the wound also actually have got some problem crops up lah, like infection, yeah. So I just briefly talk about the infection risk over here. For clean wound, example like those wound that is operated for say thyroidectomy, they are clean wound. The infection risk is about less than 2%. If it's a clean contaminated wound that is class 2, example like hernia or even colorectal cases, whereby it actually open into the cavity that is actually like not so clean, like GI tract. Yeah, so these are actually with a bit higher risk of infection that is less than 10%. If contaminated, example like those intra-abdominal injury whereby the bowel contents already gone into the abdominal cavity and all that, so the risk may be even higher, about 20%. The dirty infected class 4 wound, example like those with foreign body impacted into the wound, gunshot wound, or even sometimes MVA cases and all that, these are the infective risk higher type of wound, yeah, about 40%. Okay, I just briefly go through, yeah. So managing this incisional wound, talking about the normal incisional wound, I'm not talking about the infected wound. Normally, it is actually important to protect the wound from trauma and also any contamination, as well as protect it from infections. That's why during managing this wound, it is very important to maintain the aseptic technique and all that. Like observation is very important as well. The dressings choices, normally these type of wound are not so whippy, not so exudative. So we can just use some non-adherent gauze with polyurethane film, just like you are quite familiar with, like 3M dressing, the surgical dressing. And also sometimes maybe those wound that is a bit, you think maybe a bit higher risk of for infection one, can actually use something like hydrofiber with silver, and also the wound dressing can actually backed by some hydrocolloid. Yeah. Okay, all these are actually the different choices of dressing that can be used on incisional wounds. However, if the wound is broken down already, the wound actually may from acute wound go into chronic wound already lah, yeah. So normally for wound dehiscence is actually defined as a partial or total separation of the previously approximated wound edges, but due to the failure of the proper wound healing, so it opens up again. So this condition usually happens about 5 to 8 days following the surgery lah. Sometimes it can be also longer than that. The main reason for this are actually like ischemia, infection, increased abdominal pressure, diabetes, malnutrition, or the patient is a smoker and also obese lah, yeah. Is actually not like most of the patient come back to tell us that they have got wound breakdown because they carry something heavy or they actually exert themselves. That is not the, that can be part of the contributing factor, but it is not the main reason. Main reason is actually the infection lah, yeah. Managing this wound dehiscence, usually dressing need to be yeah, have to be very carefully selected, yeah. Because for wound dehiscence, you can actually manage your wound without any secondary suturing if you do it correctly with the right dressing. Normally, hydrofiber with silver is actually preferred dressing for use because of the absorption. Because wound dehiscence, the wound is very wet, and also silver is because the wound is also infected, so you need to manage a local infection. So silver is actually preferred rather than sometimes very deep-seated infection. The patient also needs some antibiotics, yeah, IV or something, yeah. And besides that, if the wound is actually getting better, the infection clear, they can use plain hydrofiber. They can also use agent dressing or foam dressing to manage this. In very deep wound, sometimes very big the wound breakdown, negative pressure is one of the modality that is very commonly used to actually absorb the exudate, because the exudate can be very heavy, and also it actually promote the granulation much faster. Yeah. Okay, these are the some of the management modality. And another type of acute wound is actually burn wound, burn injury. You may not see it very often unless you are working in like outpatient or sometimes in those burn ward lah, yeah, or plastic wards, yeah. Burn basically can be actually caused by thermal, chemical, or electrical. Thermal can be actually hot object, hot fluid or water, or even sometimes sunlight. Sunlight can be also one of the source of thermal burn. So besides that, chemical can be those chemical that is very corrosive. It can burn quite deep inside. Even sometimes when we talk about the patient that is actually with ileostomy, the wound fluid that is actually on the stain on around the peristoma skin, those are actually like a form of chemical burn also, because of the proteolysis enzymes and all that on the skin that burn off the skin, yeah. And also electrical burn, not very common. I have seen so far 2 only. Those are usually quite extensive and it's very deep, yeah. The wound not easy to heal for electrical burn. Okay, can I go on?
Yeah, go on,
Yeah.
please.
Okay.
No.
In managing burn, usually we are very careful about the burn surface area because the burn surface will actually determine the fluid loss and all that. So the measurement will be, I think many of you may have also heard about Wallace rule of 9. It is actually by 9% most of the places, yeah, like head and neck, and also the chest and upper back, the arms, one side is 9%, both side 18 lah, yeah, and also the abdomen and also lower back, including the genitalia, 1%. The leg is actually quite big surface area, so it's 18 on each leg, yeah, on each lower limb. And this is more suitable for adult, yeah. In children and kids, usually another classification of wound assessment is actually preferred. That is the Lund and Browder, because it is because of the proportion of the head, the trunk, and the leg. It is different from children and adult. So using Lund and Browder, it will be more accurately pointing out the percentage of burn. Yeah, can manage more accurately. And for dressing option, the treatment option, in fact, there are two different ways. If it's a superficial burn, partial thickness burn, usually by using dressing, it will heal within about 14 to 21 days. But if it's third degree, fourth degree, there's no way that the dressing can actually heal the wound. So normally need surgery like skin graft to help. Of course, the dressing will be complementary also to manage to absorb the exudate, to manage a wound and all that. Yeah. In managing wound, the timing of healing is very important. If you drag on, sometimes if it's not properly managed, the wound, even though it's partial thickness, but if you drag on, the wound can actually get infected and go into deeper, can become from partial thickness, can go into third degree, to full thickness, and that will be very complicated. So if you can manage well from the beginning, is actually able to heal within about 14 to 21 days. And also the scar quality will be good. Patients suffer less pain. Yeah, and all those are, those are the important area about wound management for burn cases. You can see some of the dressing here. I put here hydrofiber with silver is quite commonly used, and also even some places I've seen Gelonec is still quite widely used by some of the more traditional doctors, they are using it, but I think it is actually sometimes not so easy when you remove. And Gelonec, usually it doesn't absorb, and also sometimes it actually you need to remove doing the dressing like daily or 3 days once, but removing it is actually causing some re-injury to the epithelialized tissue at times. Yeah, so it is not very good to use, but still there are some cases very superficial wound. Yes, I think Gelonec have a place there. Besides that, they also can use something like this is collagen. Collagen is for superficial wound and non-complicated wound. If the wound is not with any infection, yes, they can use foam dressing, and also there are many other foam dressing and all that. It can be used. Those olden days, I think SSD is quite commonly used, but SSD no longer been in use nowadays for burn management. I think I'm not sure maybe some smaller setting they still use it . Okay, for burn wound, another important thing is when, oh, I didn't complete. So for burn wound, we have to actually manage the exudate, manage the infection, and also to reduce re-injury. Besides that, burn wound is very painful. So managing in the wound, sometimes maybe injection or analgesic need to be given before the dressing. And also the dressing should actually encourage movement. Do not use something that actually restrict the movement, because the patient do not move a lot, then they actually develop scar, they develop keloid and all that. even sometimes contracture. The picture here are the real patient actually having contractures. Yeah. Okay, now that is about the acute wounds. We have covered about the incisional wound, the burn wound, yeah, and a bit about the wound dehiscent. Yeah, now we go to the chronic wound. I will start off with the pressure injury. Pressure injury, the old name is actually pressure sore, pressure ulcer. Yeah, and actually, yeah, now the standard term is actually pressure injury. Uh, it is actually the prevalence is about 5 to 20% for acute hospital. Acute hospital, like maybe you talk about those like GHKL or maybe Beacon Hospital and all that. These are the acute hospitals, yeah. And the other thing is actually for pressure injury, the common site, the most common sites will be actually at the sacrum, 31%, followed by the buttock area. The sacrum buttock area because is the most heaviest, and also because of the bony area lah. Yeah, some sacrum is the bone prominence. Yeah, and also at the heels, and also besides that, heels is also because a lot of time the patient, if they are bedridden, they actually lying down and they don't move much. Yeah, and also, yeah, besides that, like trochanterus at the side, and also the lower limbs, all these are actually less frequent, but it happens also. Trunks is about 4%, and the upper limbs is about 3%, because most of the time upper limbs can move a bit more. And these are the okay, these are the common sites. And do you know what are the main causes of pressure injury? Yeah.
Anyone?
Yeah.
What's the main cause of pressure injury? I myself not sure. Anyone want to answer that?
You can type also. You can
Yeah,
type in the chat box. Yeah.
you can type in the chat box. What do you think is the main causes of pressure injury? I think the name in itself, the pressure.
Pressure. Yeah.
Yes,
Can be
friction. Yes,
pressure. Yeah.
friction is good. Yes, friction,
Pressure, friction,
immobilization.
and shear forces as well.
Yeah, some more. Yes,
Yeah.
so patients who are immobilized.
Mm,
Okay.
yeah.
Friction. Yeah, friction is one of the more important. Yeah,
Yeah.
bedridden. So bedridden means basically not mobilized. Comorbidity like diabetes.
Yeah.
Yes, poor healing. Yeah,
Poor immune system as
system
well.
also, vascular disease. Wow, Charlene,
Yeah.
so yes, lack of blood circulation to the area. So bed sore, Emilia, bed sore is actually pressure injury that we have just said.
Mm,
So but what causes this bed sore? There's poor nutrition, true.
mm,
Okay, Shireen seems to know a lot.
mm.
Okay,
Yep.
we can go on. Rashes, rashes,
Okay.
not so much lah. Possible, but okay.
Okay. Thank you for your
Yeah,
participation. Very good answers.
yeah, position, lack of movement on Facebook says, okay, good.
Okay. So this is actually the example of the pressure ulcer. This is the latest definition by National Pressure Injury Advisory Panel. Previously, it's actually called National Pressure Ulcer Advisory Panel. But then now, yeah, they changed the name. It is actually defined. Pressure injury is localized damage to the skin and underlying soft tissue, usually over a bony prominence or related to a medical and other devices. This is something that recently brought up quite a lot lah, about medical devices or any other devices, like catheter can be actually even diaper, even the bedpan and all that. All these can actually cause the pressure injury. Yeah. And the injury can also present as intact skin or an open ulcer. So intact skin and open ulcer, you can look at the chart here, the classification. Stage 1 is actually, can you all read? I think my slide is actually above there. The Stage 1 is actually the non-blanchable area. When you press it, the color become whitish and it doesn't come back to the normal color, yeah, for a while, but no skin break. And stage 2 is actually the partial thickness skin loss with exposed dermis, yeah, but other area is actually not really affected. Stage 3 is actually a full thickness skin loss, and also the subcutaneous tissue or adipose tissue is actually visible. Stage 4 is actually a full thickness with skin and also the tissue, full thickness skin and tissue loss with exposed deeper area like fascia, the muscle, the tendon, even ligament, cartilage, or bone. Yeah, all these are considered in stage 4. And those there are only 4 stages lah. Yeah, these are the new one. The 2 more is not that new lah. In fact, it's more than 10 years, I think. The unstageable is actually referring to those wound that is obscured. The full thickness you cannot see because it's covered by the those necrotic tissue or eschar, or the necrotic tissue like eschar, and below maybe a lot of stuff and all that. Yeah, so need to do some debridement, then only can determine the stages. Yeah, the other last one is actually deep tissue injury. This is actually something that that's persistent, non-blanchable, deep red or purple, because it's actually like bruises already, so it doesn't come back to normal color, but you don't know how deep the wound lah. So this is another category of the injury. And not forgetting also pressure ulcer. A lot of time it is not directly due to pressure, it is actually due to the moisture associated skin damage. Can be like urine, feces, can be also wound fluid, can be any other fluid that is actually associated with the area. Yeah. Okay, now we go to briefly about the wound assessment. In general, yeah, this is not just pertaining to wound, the pressure ulcer. There are many different way of looking at the wound assessment. I have taken this one is from Abel's 2022. It actually has got very detailed detailed categorization, but I think we only need to know the important area will be you know the size of the wound. That means the length and breadth, the depth, and also sometimes the drainage of the wound exudate, the types, the amount, and also you must know the color of the wound bed lah. Whether is it red or blue, or not blue. Sorry, it can be start with red, can be yellow is this slough, and also the black is the eschar lah. Yeah, the necrotic tissue. Yeah. And also pink, of course, is epithelialization lah. Yeah. And also you can also look at the types of tissue, even granulation tissue. There are many different characteristic of the granulation tissue that can tell you whether this is something that is actually very active granulating or is actually stagnant. Yeah, and also besides that, you have to look at whether the wound has got any tunneling, that whether there's any undermining at the site. Yeah. Of course, I think other things that we need to know is actually the pain affecting the patient and the odor. Yeah, all these are important characteristic that we observe in wound assessment. Okay, now another type of wound assessment, or sometimes most people refer it to be as a wound bed preparation. Like, in fact, it is also a form of a wound assessment. So it is actually a systematic approach to the wound healing, which actually involve eliminating non-viable tissue. Non-viable tissue means those tissue lah, like slough, like necrotic tissue. Yeah. Also, it control the infection. It also restore the moisture balance, and also promoting the
Okay,
epithelialized.
can you move on with the slide, because if you have slides like this, I will have a problem with my Facebook.
Oh, okay,
Yeah,
okay, I move
yeah,
on.
yeah,
Yeah.
that's fine.
Okay,
Sorry,
basically this one is actually we have to look at all these 4 areas to to make sure that we are assessing correctly and choosing the right treatment. And the next one, chronic ulcer, is actually diabetic ulcer. Diabetic ulcer can come in many different forms. Yeah, you can see there is also like carbuncle, can be actually diabetic foot, can be actually at the sole, can be actually at the toe and all that. Yeah, can be anywhere abscess. Yeah. Okay, for diabetic ulcer, a lot of time the classification commonly used is actually there are two types lah, Wagner and also another one that is University of Texas. Wagner classification actually divide into six category from 0 to 5. 0 means before the wound happened, or even sometimes is the wound already healed. Yeah, and Wagner 1 is actually referring to the superficial ulcer without any subcutaneous involvement. Yeah, and Wagner 2 is actually the diabetic foot ulcer that is penetrating through the subcutaneous tissue already. You can see the side here are all the yellowish fat tissue lah. Yeah, and then Wagner 3 is actually the wound that is actually involving the bone infection, osteitis, or actually abscess, or sometimes osteomyelitis lah, yeah, involving the bone marrow as well. Wagner 4 is actually the diabetic foot ulcer that is actually with the gangrene of digits. Digits may be 1 or 2 or maybe just at the side. Yeah, so Wagner 5 is actually gangrene of the whole area, and it can be quite bad, and the patient need disarticulation. That means sometimes they need amputation. Yeah. Okay, another classification of diabetic foot ulcer is actually the University of Texas staging, that is dividing into 0 to 3. You can see from here what is the description. Yeah, the grade 0 is actually before the ulcer happened, or actually post-ulcerative lesion, then completely re-epithelialized already. And for grade 1 is actually superficial wound, not involving tendon, capsule, or bone, a bit different from earlier one. Yeah. Grade 2 is actually the wound penetrating the tendon or capsule. And the third one is actually the wound that is penetrating to the bone or joint. Yeah. So these are the basic stage. Okay, when we use the staging, we have to use both grade 0 stage 1, grade 1 stage 1. If the grade 1 example, the patient have got infection, so the wound is actually considered grade 1 stage 2. If the wound is grade 1 but with ischemic, then it's grade 1 stage 3. If the wound grade 1 but with both infection and ischemic, then it's actually grade 1 with stage 4. So the categorization is done this way lah. Yeah. Okay. If the managing diabetic foot is not easy lah. Yeah, diabetic foot ulcer is actually quite challenging because a lot of comorbidity that you have to take care. Yeah, so maybe I will just go through some of the important area lah. Yeah, offloading is very important for not only diabetic ulcer. In fact, pressure ulcer is also offload is very important. Yeah, this is to relieve the pressure so that the wound can heal, and also you do not cause the further breakdown of the wound. Another area is actually the bacteria balance. As you know, the diabetic foot ulcer is very, very exudative. So the exudate can actually cause a lot of discomfort to the patient, can cause the surrounding skin to break further. The wound can become bigger because of the exudate. Yeah. It's quite toxic actually, those wound fluids sometimes. Yeah, the MMPs and all that. Besides that, the debridement is important for diabetic ulcer. As you know, diabetic ulcer, their blood supply is actually not so good. So the chances of forming back slough is actually very high. So sometimes you remove ID, the next day you see the slough form back. So removing the slough is actually like quite frequently you need to do if you're
Again,
managing.
can I ask you to move on because of the
Okay.
picture? I'm so
Uh-uh.
sorry,
Okay. Yeah. So
because of Facebook,
mm.
keep on saying that these pictures are all violent. So I get sometimes my whole live stream get
Oh,
what you call
sorry.
it? It's okay,
Anyway,
it's not
yeah, it's a
awkward.
bit causing
Sorry, but
discomfort
yeah,
for people. Yeah, correct.
yes.
Okay, now this one about the dressing choices. In fact, for pressure ulcer and diabetic ulcer, more or less the principle is the same. If high exudate, you just manage your exudate. If it's sloughy, you have to do autolytic debridement, remove the slough either by manual debridement, mechanical debridement, or you can actually use some dressing material to actually remove the slough lah, yeah. And also, of course, infection, you have to manage your infection by either antibiotics or antimicrobial lah. Usually, silver is used lah. Antibiotic is not very preferred because sometimes it is actually because of the risk of resistance and all that lah. But some very deep seated infection, you have no choice but to use antibiotics. Usually it's IV lah and all that, yeah. And for the wound, I managed this case actually 2020, I think. This one was the first time I saw the patient. He has got gangrene toe, already removed two. Now the third one is actually gangrene. So that time was quite whippy. I actually used foam dressing with some antimicrobial property lah, yeah. After that, when the wound is actually a bit too dry, then I use some gel and also some medihoney to actually help to soften to autolytic debride lah, yeah. And also same time I'm using some absorbent dressing. Sometime after the slough breakdown, it will be quite wet lah, yeah. And when the wound is a bit dry, then we actually when the wound is no more infection, we can actually use plain either hydrofiber or plain uh, even alginate can be used out of foam, yeah. After that, when the wound is actually getting better, we can use because when it's getting better, the important thing is to protect the wound from re-injury. So foam dressing or hydrocolloid dressing is actually sufficient. So this patient, actually I saw him in December, 2nd December, and this one is actually end of March lah. So it takes about 4 months. But to me, I think this is one of the case that is actually considering quite good result already, because the patient is quite compliant to offloading. Normally, it
I
is
think it's
actually
an amazing result.
yeah, it's not easy to actually
No, I
manage.
I think it must have taken a lot of patience, a lot of determination, and I really am so amazed at this result just by dressing, you know. So
Mm.
can you imagine how much a nurse with your, you know, your dedication can change a patient's food and life actually.
Yeah,
Yeah, I'm
yeah.
so proud of you.
Thank you. Actually, I think most wound care nurses will do the same, because actually when wound care nurses do dressing, they don't just do dressing. They want to do dressing with an objective to heal the wound. That is the difference. Because a lot of time, sometimes people do dressing, just do dressing to clean the wound. That is their main objective. But for wound care nurses, I think we have an objective to how to heal the wound. That is our final objective. And also like this patient, how to prevent amputation. Okay, now the next one is also a chronic wound, that is actually leg ulcer. Leg ulcer, there are three types. Yeah, venous leg ulcer, arterial leg ulcer, and also some mixed. Venous and arterial is mixed. Yeah, some. Okay, in managing venous ulcer, very important, we need to know whether the wound is actually a venous ulcer or arterial ulcer. Otherwise, you do the wrong treatment, it can be very fatal for patient. Example, if the patient have got arterial ulcer and you do not know, you use a compression bandage, actually you are actually compressing the blood supply, and actually patient can have amputation because of that, yeah. Okay, now the diagnostic tool, normally there are many diagnostic tool can be used like Doppler, like duplex, all those imaging can be managed by doctors, can be managed by nurses, trained wound care nurses lah. But then a lot of time the setting don't have all this. The best way is actually to do the ankle brachial index ABI. Doing the ABI is actually you measure the pressure at the ankle, and then also you measure the pressure at the brachial. So when you put the ankle pressure, systolic pressure of your ankle over the systolic pressure of the arm, uh, then you can actually have the results. Yeah, normal ABI usually is ranges by about 1 to 1.4. Usually the brachial systolic will be slightly higher than the ankle lah, yeah. And also if it's lower than 0.9, that indicates some form of arterial disease. Yeah, and also there are also other methods that they can actually do a bit more invasive to actually diagnose. Yeah. Okay, so now come back to
Okay, we have to stop now because stop. Don't show this video, please. Don't show anymore.
okay. Yeah.
Sorry.
Mm.
Okay, the problem with the talk is it's not you at all. Sorry, your talk has been amazing. It's just that whenever we have this type of talk where we have to demonstrate wounds and all, Facebook keep on
Yeah.
deleting my my webinar, my live stream, because they say that it is against their, I don't know what is it
Okay.
called.
Okay. Yeah. Yeah.
So again, Facebook just deleted my webinar. So I think
Okay.
that we will have to stop here. I'm going to send the webinar link, and I need to think of ways to, no, the ESET link, and I need to think the ways to overcome this Facebook. Can I ask you, anyone out there, if YouTube is a better choice or not? Is YouTube a better choice?
Slightly. Yeah.
You think so?
I'm not very sure, but
I also never
maybe
use
some
YouTube.
of our audience here can
Okay.
actually give some suggestion.
Yeah, maybe our audience can give some suggestion. Because YouTube has deleted, and I'm so worried that they will actually block my page,
Oh.
delete my page completely.
Mm.
Yeah. So I'm not sure how. Okay, so I'm going to share I already shared the ESET registration form. So you just fill up the ESET registration form and then wait for the cert. Please wait, because we have so many people registering, we can't cope. We can only send out 100 to 300 a day. And that also we're working non-stop. And I'm alone with one intern. So please wait. Yeah. So I'm going to put the form until about 10:40. Maybe you can stop sharing the slides.
Okay. Yeah.
Okay. And then we have a question. Any question at all? Okay. So sorry. You are an amazing speaker. You put in a lot of work, and I can see the quality of your slide is very good. There was a question. Any questions at all so far? There was one, I think somebody asked. Can you see it?
No, on the chat box there is none.
How come? There was one just now. What is the use of AG? AG is what?
Oh, okay. AG is actually okay, the scientific name is called argentum. It's
Yeah,
a
I can
type of
tell.
silver. Silver is actually known to use for antimicrobial property lah. That means to kill germs, like on the wound. Local infection lah. Manage local infection.
Google Meet. Everybody say can do Google Meet.
Oh,
Google Meet got how many, how, any maximum numbers? Okay, Charlene asked would be the best choice of,
let
uh,
me see.
best choice of dressing in each grade of sacral sore.
No, actually, we look at the characteristic of the exudate and also the type of tissue. So there's no specific dressing for pressure ulcer grade 1. I mean pressure ulcer, partial thickness, and all that. But for very superficial pressure injury, very often we use hydrocolloid. Yeah, it's actually because there's no ulcer, so you use the you very superficial, so you can use hydrocolloid to heal it quite fast. Yeah, effective, and also with yeah.
I've already shared the link for registration, yeah? So please look for it. The problem with the, hello? Where are you now? Huh? Okay, the problem with a lot of the nurses are, they keep on asking. For example, they'll ask me, why is it not sent yet, the e-cert? It's like, tonight is the e-cert, is a webinar. Tomorrow morning, they ask me, why is the e-cert not sent yet? It's really ridiculous, okay? And then they're not paying attention. Every time I tell them, okay, I am sharing the e-cert right now. And then they don't register until the webinar is over. Then they keep on asking, why can't go in?
Mm.
And there's also another thing is that you must pay attention. Okay, there is another question. What about grade 3 and grade 4 sacral sore?
Okay, grade 3 and grade 4 sacral sore usually is a bit more deep and also a bit more exudative lah. So the exudate management is good. And also grade 3, grade 4 because of the exposed tendon, exposed bone and all that. So you need moisture. You cannot leave it very dry. So you need the dressing as you need the exudate management dressing, but at the same time you have to manage the moisture balance so that the bone or the tendon wouldn't dry out. Dry out means it will actually it will become necrotic and yeah, it's actually harmful lah to.
Okay, we have some question. Melissa Prabhakaran on Facebook asked, is Medi Honey available for purchase over the counter?
I think so. Yeah, it's actually available in pharmacies, I think. Yeah.
And then Haslina asked, what about unstageable of wound? Sometimes wound care nurse will decide unstageable. I don't know the exact gist of the question. Haslina, you all can ask the question in Malay. It doesn't matter. We can. So
Yeah.
okay, Nguyen Chua asks, what's your opinion of using hydroiodine
Hydronorate.
for
Oh.
wound?
Okay. On that, I don't have much experience on that, but I know it can be used in actually to actually keep to manage the bacteria balance and all that lah. Yeah, I can't share much on that because I don't have experience using that.
Okay. Hold on. Any more questions?
back to just now the unstageable. If
Yes.
unstageable, I think the first thing they may need to do some debridement to know exactly how extensive is the wound and then what is involved and whether it, usually deep wounds like that it will be quite wet lah. So exudate management dressing like even hydrofiber or even alginate foam, all these are very suitable dressing to manage the wound. But at the same time, not too, if you assess the wound again, if it's too dry, then you have to add some moisture to it, like from gel or from even from Medihoney and things like that.
Okay, so I'm going to share this one now. Okay. Oh, so sorry, there are some more questions from the other Facebook. Is moisture releasation also called term as pressure sore?
Yes, yes. We also call pressure sore. But most of the time, if you know it is actually moisture associated skin damage, then we just directly use the term like MAST. But you can say pressure ulcer, it is not wrong because it's ulcerated. Yeah.
And this So Heng Mui, who's asked that question, wants to know what is the best dressing for this?
For
For this moisture
For those okay, for the
pressure
moisture associated
lesion.
skin damage, usually you need to actually make sure that if the patient is using diaper, the diaper need to change quite frequent lah, not to say the diaper so wet until the it's always soaking at the area. You can use some barrier cream if the skin is no wound yet lah, yeah, just preventive. But if it's already there is some skin break already, then you have to use something like hydrocolloid will be good because usually beginning the wound is not that deep yet. You can use hydrocolloid. If it's deep already, then again, if it's deep and also it is quite exudative, you have to use absorbent dressing lah. Any exudate management dressing like hydrofiber, alginate or foam. All these are managing the exudate.
Okay, there are a lot of questions, so it's very interesting. Has Roslan asked, selalu grade 3 ke 4 back sores, ambil berapa lama masa untuk lega? Means untuk rawat, I rasa.
Okay, yeah. Okay, kalau luka tu stage 3 usually kalau dia tak ada banyak comorbidity lah ya. Example like sometimes patient is because stage 3 because dia how to say dia paralyzed lah ya, bukan sebab lain tak ada lain comorbidity like diabetic and all that. Normally stage 3 younger patient, I think dalam 3 bulan, depends on the size juga lah. Kalau size dia lebih kurang 3 inci, like 3 inci, or maybe say about 7 by maybe 8 by 8 cm, maybe take about 3 months lah, yeah. But sometimes if the wound in between your management, the wound become infected, luka tu akan jadi besar lagi. So you need to consider that lah. Bukan selalunya kalau that roughly that timing lah. Sebab itu chronic wound we say no predictable healing time lah. Ya, selalu susah nak cakap.
Yeah, but as you can see that Miss Wong demonstrated one that she actually took 3 to 4 months, yeah. Okay, Kelvin asked, is barrier cream preferred compared to barrier skin spray?
Barrier cream, I think both are more or less the same function lah. Depends on how what your preference is lah. Barrier cream maybe a bit more moisture retentive, I think. Yeah.
Okay, let me see what time. Okay, we still have time. How about, okay, we've done unstageable. How about hydrofiber dressing with silver for pemphigus vulgaris patient? I think this is out of the scope, yeah?
They do
Because
use, they do use
do they
actually.
use?
Sometimes, yeah, those fan figures in the exhibition, they have got very bad those lesion. They have to be admitted. They do use yeah, they do use aquacell. I mean the hydrofiber with AG, or sometimes just plain hydrofiber. It helps to actually reduce the lesion. I've done that before.
Okay, good. So usually Aquacell Argentum can keep for how many days?
Aquacell agentum for those wound that is very badly infected, we will advise to change maybe alternate day or even daily sometime. But most of the time is about 2 to 3 days, then you change once lah. For burn wound, you can leave the Aquacell AG or the hydrofiber AG dressing. Maybe other hydrofiber, I'm not sure, but I'm talking about Aquacell AG. You can leave the dressing on for up to 14 days until the wound heal, then the whole piece will come off. That is that in particular that hydrofiber lah. For the normal like pressure ulcer and diabetic ulcer, usually about 2 to 3 days. Yeah.
Okay. Now, there is a question here. Star what now? Star Sugar ask, okay, the usage of honey for wound management, can Manuka honey be used?
Usually it is not advisable to use like those besides Medi honey lah, because medical grade it is actually safer lah, because you can exclude all those like you know, sometimes all these infection that you never know lah, yeah, from honey and all that. There are a lot of things that it is not really you do not want to cause more infection to the patient.
Okay, I cannot understand why people cannot find the link. Okay, 800 over people have registered for the eCert now. So if you say you can't go in, you can't register, you can't find, I said then you don't deserve to get the eCert because already so many people can register. You understand? Okay, Danish asked kalau guna hydrogel.
Mm.
Hydrogel is
Maybe just a brand name. Yeah, Hydrogel is those yeah
is it
hydrocolloid gel
bagus
lah.
tak? Bagus tak untuk patient?
Untuk patient yang luka dia kalau terlalu kering, perlukan kelembapan, jadi gel adalah digalakkan lah, bukan saja satu brand lah. Actually any brand of hydrocolloid gel boleh digunakan. Kalau luka tu terlalu kering, ada slough ataupun dia ada necrotic tissue, maksud dia terlalu kering lah ya. So kalau necrotic tissue atau slough tissue tu tak dibuangkan, dia ubat-ubat apa kita guna, kemudian dia tak akan penetrate ke dalam. Jadi yang gel tu bukan saja boleh donate moisture pada wound bed, tapi dia juga autolytic debride, dia boleh buangkan slough tu. Untuk luka-luka macam tu sesuai ya. Apa brand I think also can use.
Okay, I think we will stop questioning now. Okay, someone has asked for the slides. Yes, Miss Wong has sent me the slide. I will share it on the Telegram group chat. Okay, I will sit down with Miss Wong to discuss how we can improve on our nursing webinar. And maybe she can actually host it instead of me. I'm thinking. We see how it goes. But I really think this nursing, you see, the doctors have a lot of webinars, a lot of symposium. Whereas I realized that nurses actually seems to be very eager to learn, but no not enough facility, not enough, channels. So, I have already shared the e-cert link.
Ah,
So
scroll
I'll
sampai
share,
atas. I think it's very earlier ada. Boleh
I'll
scroll
share
atas.
again. Waiting, meeting group. Okay. Okay, this is the last time I'm sharing. And then, thank you very much. I will try to improve and on this nursing thing. And I'm so sorry that we cannot continue this webinar with your slides.
It's
I
okay.
need to think of other ways. This is not your first time. The other day we had one with the reconstructive surgery. So all the slides were really, about trauma. It's a bit gory. So also I was warned by Facebook and restricted, for 3-4 days.
Oh,
So it was really a bit difficult. Okay. Happy New Year, Happy Chinese New Year to everyone, and happy long holiday. And join us again next month. We also have a webinar on postpartum care, which also my friend Su Yin from Canada is going to give. And she is also a very good speaker. So, Miss Wong, Happy New Year, 恭喜发财.
thank you, Dr.
Bye,
Becky, and Happy New
everybody.
Year to you too.
Yeah,
Happy New Year to all
I
those who are
message you.
celebrating. Yeah.
Yes. Okay, bye-bye.
Bye. Thank you.